Hi, everyone.
Hey,
Hey, Amarani. Hey, Brianna. Sees it Lolly, Abrela, and Brittany. How's it going?
Good. How about you?
Not too bad, thanks.
Good.
Nice to kind of get a break away from the classroom, right? Right. So let me see. What time is it? It's 5:30 now. I'm going to go ahead and get started. Let me see. I'm just going to share my screen here. Give me 1 second. Can you guys all see my screen okay? Yeah, okay. So let's see, 1, 2, 3, 4, 5 of us here. Hopefully the rest of the class will join soon. But what we're going to be doing is talking about chapter 20. This starts on page 447 of your textbook. This is the big blue dental assisting textbook from cengage. And chapter 20 talks about anesthesia and sedation. And so some of the things that we're going to be talking about with this is some various topical anesthetics and their placements. We'll talk about local anesthetics, the different types of local anesthetics, some of the injection sites involved, some equipment, some materials that you'll need for these types of anesthetics. We'll also describe or list the steps of preparing for the administration of anesthetics, and then some supplemental techniques as well. We'll also talk about some nitrous oxide and some sedation techniques, and then how to assist with the administration of nitrous oxide. All right, so anesthetics and sedation reduce pain, and well, anesthetics reduce pain, sedation relieves anxiety. So many patients are very anxious about dental care and treatment. Sedation is one method of managing the anxiety of the patient, and anesthesia also can be used to control the pain a patient experiences. Depending on the need, various levels of sedation can be achieved, from conscious sedation all the way to deep sedation. And by the way, sedation is just a state of calmness or the process of reducing nervous excitement. Conscious sedation places the patient in an altered level of consciousness. The patient is still able to communicate and respond to questions, and this form of sedation serves to lower the levels of pain and discomfort. The patient may experience a headache, nausea, and some brief periods of amnesia following conscious sedation. With IV sedation, anesthetics are administered directly into the bloodstream and remain in place throughout the procedure. The patient may remain conscious but is in a deeply relaxed state, and the patient often has no recollection of the events that took place while under anesthetic. This form of sedation keeps patients relaxed, comfortable, and pain-free. Oral sedation is achieved by taking a medication the night before the dental procedure. So this may be prescribed for the patient who is extremely anxious about the procedure to be done. Benzodiazepine is one of the medication that's often used for this type of sedation, which is a hypnotic. And this makes patients calm and drowsy, or an anti-anxiety drug might be used, which makes the patient calm and relaxed. Inhalation sedation may be needed when it's difficult to achieve IV sedation. So the anesthetics are administered in a gas form by inhalation through a mask. This will cause the patient to become sleepy and serves to relieve the pain. The patient often doesn't remember much of the procedure, and it's not long lasting, so the patient must be carefully monitored to make sure that they've been sedated properly, or that they remain sedated throughout the procedure. Intramuscular sedation is an injection that's given directly into the muscle of the upper arm or thigh. It is not commonly used, but it may be seen in pediatric practices. And it takes about 20 to 30 minutes for it to take effect with this route of administration. General anesthesia provides a deep level of sedation that creates an unconscious state. So the patient's vital sign must be closely monitored, and the patient will be on a ventilator for the duration of sedation. That's how deeply sedated they'll be under general anesthesia. So general anesthesia alters and depresses the patient's central nervous system so that the patient will lose all feeling and sensation. Topical anesthetic is often used prior to local anesthetic. The nerve endings in the mucosa are desensitized, causing numbness. This alleviates the sensation of the pinch of the needle that's used during local anesthetic. Local anesthetics are used to reduce the sensation of the pain. It reduces pain, touch, and heat to a particular area. So this type of anesthetic works on the nerve fibers to block sensory impulses. So it is best to have a patient be cooperative, conscious, and relaxed for most procedures. So we do this through local anesthetics, and topical anesthetics are available in gels, ointments, liquids, or sprays, which help to prepare the area to accept the needle for a local anesthetic without pain. Usually benzocaine or lidocaine is used for this. And these are used for topical anesthetics anyway, can be used for things like subgingival scaling. So when we go underneath the gum tissue to clean out debris or bacteria, it can be used for root planing. Root planing is just another type of gingival scaling, but we go deeper than the gum tissue. It can also be used for seating crowns, for placing a matrix band. Sometimes those matrix band dig deep underneath the gum tissue, and so it can be a little uncomfortable for a patient if they're not completely numb. For periodontal probing, if they're really, let's say they're really sensitive, preparing for local sedation, or repressing the gag reflex. So a lot of times when we have to take x-rays on a patient and a patient has a really bad gag reflex, we can actually use a topical, it's like a spray that we can use to suppress their gag reflex that way. So some of these topical anesthetics can cause an allergic reaction of up to 24 hours after the application. So this reaction may cause swelling, redness, ulcerations, can cause difficulty swallowing and difficulty breathing even. A toxic reaction can also occur, and initially the patient will become more talkative, or even apprehensive, or even excited with an increase in blood pressure and an increase in pulse. So here we have somebody placing topical anesthetic. And what you want to do first is on that first picture, we see somebody drying the area that anesthetic is going to be placed. This is really important because otherwise the saliva will carry it everywhere else in the mouth other than where you actually want it to go. Also, the saliva will decrease the effectiveness of it. So we have to make sure we dry the area first with gauze. And here we see that person placing topical anesthetic in the upper mucosa. And this is them placing anesthetic on the lower mucosa. Notice how they have to pull the cheek back a little bit so that they can get to that vestibule area where that injection is going to be placed. So that's very important. Local anesthetics are primarily used to alleviate and control pain during a procedure. They come in liquid form and are injected into the tissues. A short duration local will last about 30 minutes. An intermediate duration will last about 60 minutes. And then a long duration can last up to 90 minutes. Local anesthetics may also contain vasoconstrictors, which constrict the blood vessels to reduce blood flow in the area of the injection site. Vasoconstrictors reduce the levels of anesthetics entering the bloodstream, thus reducing the chances of a toxic reaction and decreases the blood flow at the site. So epinephrine is the most commonly used. Has anybody ever heard of epinephrine? Anybody know what it is? So epinephrine is a type of adrenaline that our bodies naturally produce. Cardiologists will use it in order to restart the heart because it's basically pure adrenaline. And so in dentistry, we use it as a vasoconstrictor in order to close the blood vessels. Now, sometimes that epinephrine can inadvertently get into the bloodstream. And what we will see is effects of adrenaline entering the patient's bloodstream. So this can cause patients to be apprehensive. It can cause their pulse to increase. It can make them feel like their heart is beating out of their chest. So after we give a patient some local anesthetic and you have your patient experience that, usually what you want to do is you tell patients that this is completely normal. It happens sometimes. Sit them up, then just let them know that this is a little bit of adrenaline that entered their bloodstream. It will go away in the next 20 minutes. But you usually don't want to start any dental treatment until they're feeling better. Okay, this is another reason why we take blood pressure before we administer any local anesthetics, because, excuse me, because of the possibility that this can happen. Now, if you can imagine somebody that has a high blood pressure already, and then we have epinephrine entering their bloodstream, what do you think can happen? They can get a heart attack, like have a heart attack, right? Too much, if they have high blood pressure already, this will make their blood or their heart pump even faster, and it can be actually pretty dangerous. But normally this is not dangerous. It can just make somebody feel like their heart's beating out of their chest. So some possible complications of local anesthetics are, one is a toxic reaction where a patient becomes ill. And so there's many factors that go into this, but a lot of the time it's because of an overdose or too many carpules of anesthetic were administered, the type of anesthetic that was administered that that patient possibly might have sensitivity to, or some other type of individual characteristics. Now, some of the symptoms can include a drop in blood pressure, vomiting, pallor where the patient kind of loses color in their face, convulsions, muscular twitching, and apprehension. So another thing that can happen is paresthesia, where the numbness does not go away as expected. And this can last a few days or up to 8 weeks, and sometimes can even last even longer than that. On very rare occasions, that it's an indefinite period where the paresthesia never goes away. So causes of this may include nerve sheath damage during the injection, where the nerve was actually punctured by the needle, and the nerve sheath is damaged that way, or hemorrhage that causes pressure on the nerve, or a contamination of the anesthetic. So any one of those three things can cause paresthesia. Okay, who can tell me what a state of calmness or the process of reducing nervous excitement is called?
Sedation.
Who said sedation?
Brittany.
Brittany, you're right. Good job. Thank you. And so, yeah, that's basically what a sedation is. So very good. All right. So now we're going to kind of go into the types of injections. So one of these are called local infiltration. And so local infiltration is used for various dental treatments that include root planing, soft tissue inclusion for biopsy, a gingivectomy, or a frenectomy. So a local infiltration is one injection that surrounds the tissue or one tooth. So this is an injection site near the terminal nerve branches. If you can look closely on where these little blue lines that are kind of indicating where the nerves would go. So the terminal branches are the ones that branch out just before it hits the nerve, or before they hit the tooth. Okay, so remember that, where that location of that little circle is. The next type of injection is a field block, and this is an injection near the large terminal branches. So just kind of one more fork up from wherever these terminal branches are is the field block, which is one of these larger branches here. So the field block infiltrations are given near the apex of the tooth and involve one or possibly two teeth. So usually the patient feels numb within 2 to 3 minutes of this type of injection. So once again, this is 1 to 2 teeth is what a field block would take care of. So a nerve block eliminates sensation over a larger area of infiltration or field block. So a nerve block is up at the very top of the branch near the main trunk of the nerve. Okay, so it is used to numb an entire region and usually takes effect within 5 minutes. So these do take a little bit longer for them to reach all of the areas that the dentist is trying to block. So sometimes these can block up to an entire quadrant. So once we get into a little bit of the injection sites, I'll go into a little bit more detail with that. Okay, so these are some of the injection sites, and we're going to start with the maxillary arch injection sites. So these are a lot here. You don't necessarily have to remember all of these for any given test, but I do want you to be familiar with them enough to be able to know what they are if somebody mentions them, because in the office that you'll be kind of expected to know where they are. The dentist tells you, okay, I'm going to do such and such nerve block. You'll need to know where to place the topical. So the first one we're going to go over is this one called the anterior superior alveolar nerve block, fancy word, right? Or an infraorbital nerve block. And so what this one covers is, let me get to my pages. So this one is near the height of the mucobuccal fold at the maxillary first premolar. So the mucobuccal fold is where you're kind of inside of your lip meets your gum tissue, right in that fold area. And so what this will do is it'll numb the maxillary centrals and lateral incisors and cuspid. So these three teeth that we kind of see shaded in green can all be numbed by this one injection site. The next one is the middle superior alveolar nerve block, which is this kind of bluish color here. This injection site is at the apex of the second molar toward the distal buccal root. So the second premolar, hold please. Yeah, the second premolar. And so what this will do is it'll block both premolars and it'll actually block the first or the mesial root of the first molar here. And so it's kind of up at the mucobuccal fold, right in this area. It's on the buccal side of that premolar. Okay, the next one is this posterior superior alveolar nerve block. And so this injection site is at the apex of the second molar toward the distal buccal root. So the second premolar here. And this will actually numb the hard palate, actually the maxillary second and third molars, the distal buccal and palatal roots of the first molar, and the buccal tissues adjacent to these teeth. So basically all these three teeth that this little purple square encompasses here. The next one is a greater palatine nerve block. This is anterior, this injection site here is anterior to the greater palatine foramen. And it's middle of the maxillary second molar on the palate. So middle of the maxillary second molar, right here. The first one is here, second is here. And this is on the lingual side. This is on the roof of the mouth, the lingual part of the anterior side, the posterior side. So this is a very painful injection. Probably one of the most painful of them all from my experiences anyway, and some of my patients' experiences. But what this will numb are the hard palate, the soft tissues covering the hard palate from the distal of the canine. So the distal of the canine and all the teeth posteriorly. So if you want to numb basically all of these teeth, that one injection site will cover them all. Okay, the last one on this slide here is a maxillary nerve block. So this one, so the maxillary nerve block's injection site is at the height of the mucobuccal fold above the distal of the maxillary second molar, above the distal of the maxillary second molar. So this area here. And what it will numb is the buccal, the palatal, and pulpal tissues in one quadrant. It'll also cover the skin of the lower eyelid and the side of the nose, the cheek, and the upper lip. So when the patient tells you, oh, my eyeball feels numb, that's normal. That's normal. So just kind of reassure them of that. Any questions with this slide at all? Okay, let me just, I can't see everybody. 1 second. I want to see everybody. Aha, there we go. Okay, so let's go on to the next one. Oop. All right, so this next one here covers, just want to make sure. Okay, so this next one here covers the mandibular injection sites. So the first one is the inferior alveolar nerve block, also known as the mandibular block. And that one is this green box that you see here. So with this, the injection site of this is on the ramus, it's lingual of the retromolar pad, so that if you were to run your tongue, the very, very back portion of the very back tooth, you see that kind of pad, you kind of feel that pad where, which is basically gum tissue. So it's on the lingual side of that. And what that will do is numb all of the teeth and the entire quadrant up to the lateral incisor here. With the lingual nerve block, it is lingual to the mandibular ramus and adjacent to the maxillary tuberosity. And this one will kind of numb all of those areas. So it's just a little bit higher and a little bit more lingual than the inferior alveolar nerve block. But this one actually covers all of the teeth in that quadrant, including that central, the central incisor of that lower, the lower arch. The next one is the mental nerve block. So those of you that kind of remember sequence 3 and radiology, where we talked about all the different landmarks, remember that mental foramen, right? The hole right on the bottom here that sometimes looks like abscess. Well, that is where we stick the needle for the mental nerve block. And so if you remember why we have that hole there, it's because that's where a lot of different nerve endings and blood vessels come out of and go through the lower jaw. And so what that'll do is it'll numb the mandibular premolars, it'll numb the canines, and the facial tissues adjacent to these teeth. So basically all the teeth that are colored here in this green color will numb all of those. The incisive nerve block is at the height of the mucobuccal fold in front of the mental foramen. And so these will numb all of these teeth here shaded in purple. And then the buccal nerve block is the injection site is on the buccal side of the most distal molar, which is usually that third molar here. And that will numb all of these 3 molars here. So the first, second, and the third molar. All right, who can tell me which injection will affect the hard palate and soft tissues covering the hard palate from the distal of the canine posteriorly?
The greater palatine nerve block.
Yes, the greater palatine nerve block. Very good, thank you. So yeah, that will numb all of those areas. So these nerve block injection sites are really important to know because especially for patients that are getting multiple teeth worked on and they don't like needles, let's be real, who really does like needles? This will enable the dentist to numb all of these teeth with one single injection. And so by knowing where all of these injection sites are, you'll be able to assist the doctor in knowing exactly where to put the topical anesthetic. Okay, good. So these are just some of the materials that you'll need for anesthetizing a patient. First, you'll need their health history, right? You'll want to know what they're allergic to, especially since we're giving them injectables. Also, if they have issues like high blood pressure, anything like that, where it will affect their heart. Because we're playing with epinephrine, which could get into their bloodstream, we want to make sure that we're keeping our patients safe. Okay, also you'll see on this armamentarium is, you'll see a Q-tip. We'll see some topical anesthetic cream or topical anesthetic jelly, whichever one your office is using. We'll see a shorter blue needle, a longer yellow needle. There could be different types of anesthetics here. I think this is lidocaine and this looks like septicaine here. You'll need your aspirating syringe, which your needle and your anesthetic is connected to. We'll need some gauze, right? So that we can place a topical anesthetic and not have it go all over the mouth. A high volume evacuator, an air water syringe, and then a basic setup, which includes cotton pliers, an explorer, and a mouth mirror. Okay, so I want to go over some parts of the aspirating syringe. So there's various types of syringes that could be used in dental procedures. The most common is the aspirating syringe. And this type of syringe allows the operator to verify that they have not penetrated a blood vessel. So with this, the harpoon of the syringe is retracted, so they'll inject the patient, and then they'll go ahead and retract the harpoon so as if they're drawing in fluid. And if blood appears in the syringe or inside of the glass tube of anesthetic, then they know that they've actually entered the blood vessel and they need to move their needle and reposition. Okay, who can tell me why they wouldn't want to put anesthetic directly into a blood vessel?
Because you don't want it going into the bloodstream.
Exactly, especially since we're playing with epinephrine. If we inject them with epinephrine, that's basically adrenaline going into the bloodstream. This can cause them a panic attack or have them feel like their heart's beating out of their chest. And that's for a good situation. A bad situation would be them actually having a heart attack or some type of heart issue on your chair, which we definitely don't need. So dentists use an aspirating syringe for that purpose. Good. So the parts of the aspirating syringe are the thumb ring, which we see here. We see the fingertip or finger grip bar, which is this area here. This is where they'll kind of grab onto it with their two fingers. We have the syringe barrel, which is this long piece here. This is where, if you think of like the barrel of the gun, this is where the anesthetic sits in, or that tube of anesthetic, known as a carpule of anesthetic. We see the plunger, which is this, this kind of cylinder inside. And then this kind of spiky part here is called the harpoon. And then we have the threaded end of the syringe, which is where we would thread the needle into. Okay. Now, this is what basically a needle looks like. And so there's different types of needles that we use. A short needle is this blue needle here. This one is 1 inch long, and it's used for infiltrations and field blocks. It can also be used for a periodontal ligament injection. This longer one here is 1 5/8 inches long. This is used for nerve blocks, maxillary and mandibular, although it's more commonly used in mandibular arches. It'll reach the posterior areas and for areas that require penetration of thicker tissue because the gauge of it is thicker. So the smaller the gauge, the larger the diameter of the needle. Okay, so just remember that a larger, so like let's say we have a 30 gauge and a 25 gauge, the 25 gauge will be a thicker needle than a 30 gauge, okay? So then we have several parts of the needle itself. We have the bevel here, and I know you can't really see it in this picture here, but if we were to really zoom in, the tip of this needle is kind of like a beveled or slanted shape. That's just so it's easier to get or to puncture the tissues. It's also where the anesthetic leaks out of. And then we have the shank of the needle, or the long part of the needle here. We have the hub, which is the silver part, and then the syringe end. The syringe end does not have a bevel. Instead, it punctures into the anesthetic carpule, and that's where the anesthetic comes from. Okay, so this slide kind of goes over needle care and handling. So these needles are made of very, very thin pieces of metal, okay? And after a while, they'll fatigue. And so we want to make sure that we keep our patient safe. So we don't ever want to puncture the patient more than 4 times before we go and get a new needle. If we do, what can happen is the needle can break inside of the patient's gum tissues, which can be a very traumatic experience for both the doctor and the patient. So if you ever see a doctor injecting more than 4 times, just politely offer them a new needle, and that'll kind of jog their memory, like, oh yeah, I need to change that needle out before my needle breaks. A lot of the times the doctors will actually bend the needle because they wanted to get it into a certain injection site without having to bend their hand in so many different ways. Okay, with needle care, there's also safety. So you want to make sure there's some type of stick prevention device that's used. So there's different devices that we have. Sometimes they're basically a piece of cardboard that some of us have seen in class before. Sometimes they look like these little blue rubber pieces. We also have caps and shields on the needle to prevent any needle sticks. And every time you throw away a needle, you never want to throw the needle away in the garbage. That can be dangerous to anybody having to, for whatever reason, dumpster dive in case somebody throws an impression away on accident or a model away and somebody has to go rummage through the garbage. I've done it before. So you don't want to actually cause that safety situation for somebody. So always make sure you put the needle in the proper disposal. Should always, always, always go into a sharps container right away. Don't even let it set on the tray once you're done with it. Put it directly in the sharps container. Okay. And then also you want to follow OSHA guidelines. And then if a procedure, the procedure for if a needle stick does occur, okay, the first thing you want to do is immediately squeeze the area where you pricked your finger. Squeeze it until you see blood dripping out. The reason for that is in case you get, if you do inject, or if you do stick yourself with a dirty needle and somebody has something, you want to push that out of your finger as much as possible. Okay, then you want to go to a sink and you want to wash the area really good with an antimicrobial soap, like your life depends on it. So you want to scrub that area really, really good. Then notify the dentist and find out which patient the instrument was used on. Okay, then you want to review that patient's chart and medical history just to make sure you don't see anything like, some type of bloodborne illness that the patient has, HIV, AIDS, any of those scary things that patients could possibly have. Okay, and then follow OSHA protocol for occupational exposure to bloodborne pathogens. So sometimes the office will have you go into a clinic and get what's called a prophylaxis treatment. Well, they'll actually pump you with antiretroviral drugs just in case you did go ahead and expose yourself to something scary. So there's different protocols depending on your office for something like that to happen. Okay, so here we see an anesthetic carpule, or sometimes people call them a cartridge. And so the parts of this cartridge are, first of all, it's made of glass, okay? Since it's made of glass, we have to be very careful. We don't want to ever squeeze it in our hand. And if it falls on the floor, which sometimes it does, even if you wipe it with Cavicide, it's still not good anymore. Throw it away. That's because if you drop it on the floor, it can crack. And sometimes you won't know that it's cracked until you go to inject a patient and the thing explodes over everybody's face. So never reuse a cartridge if it's fallen on the floor, even if you wipe it, okay? So one part of this here is a rubber stopper or plunger, which we see here. This is where the harpoon will gauge inside of the anesthetic cartridge. Then we see the aluminum cap, which is on the other end of the cartridge here. And then the diaphragm. The diaphragm is just made of a thin piece of rubber, and that's where the needle will engage into the diaphragm there. It'll puncture the diaphragm, and that's how the needle will get access to the inside of the cartridge. Everybody okay with that? Okay. All right. So preparing the anesthetic syringe, you first want to select the disposable needle and the specified anesthetic that whatever your doctor likes to use. Remove the sterilized syringe. So it should be in some type of sterilized package. Fully retract the piston rod. Place the cartridge in the syringe. Then engage the harpoon. Remove the protective cap from the syringe and secure the needle onto the hub. And then holding the whole thing upright, so needle facing up, you want to expel a few drops just to make sure the syringe is functioning properly. Make sure you didn't accidentally bend the needle. You want to actually make sure that you get drops out. If there's no drops that come out of the needle, it's probably because you bent the needle. And that happens sometimes. Just take the whole thing apart and start over again. Okay, and then you want to replace the protective cap over the needle to make sure nobody sticks themselves. So what does that look like? So retracting the harpoon, you'll grab the harpoon in one hand, and then you'll use your thumb to push up on it. It's a spring-loaded thing, so you want to push up on it. This will retract the harpoon enough so that you can slip in your cartridge. Okay. Once you load the cartridge in the syringe, you want to load it with the rubber stopper first. So this rubber stopper should be facing the harpoon, not the other way around. Okay, then once it's engaged, you want to give the harpoon a couple of good taps. That'll engage the harpoon into the rubber stopper and secure the cartridge into the syringe. Okay, the next thing you want to do is place your needle. So you'll take the safety cap off the needle and then place it inside. You're going to have to puncture the diaphragm, so you got to push in a little bit, and then there's this whole thing here. This here is threaded, so you'll screw it in, righty tighty, lefty loosey. Spin it so it turns to the right until it's completely engaged. Okay, and then after that, after drying the inside with the gauze and placing the topical anesthetic in the injection site, you want to pass the needle to your dentist, and then you want to pass it in this way. So you're going to pass it with your hand over the needle capping device, or the needle cap, and hold it to them so that they can grab it towards this end, wherever the thumb ring is placed. Okay. And then some doctors will want you to actually squeeze down with your pinky so that when they grab it, you remove the cap for them. Some of them don't want you to do this, and that's okay too. Just simply pass it to them and they'll do the rest. Okay, when you're disassembling the syringe, you're going to retract the piston to release the harpoon from the cartridge and remove the cartridge from the syringe. After you do that, you'll unscrew the needle, put it directly into your sharps container. Some offices have you place both cartridges and the sharps container, both the cartridge and the needle in the sharps container. Other offices will actually have a separate receptacle for the cartridge. That'll be like a white container with a blue top. It's what we call a pharmaceutical waste container. So just check with your office management to see what types of receptacles they're using. Okay, so who can tell me what you need to do in the event of a needle stick? So there's several steps. Who would like to share?
Okay, so you push it out as best as you can, and then wash your hands really good, and then review the patient's chart to see if they have any bloodborne illnesses. And
Yes.
then something about OSHA.
Yeah, good. So first, push it out, right? You want to push all the blood out first. Then go to the sink, wash the wound with soap and water, notify the dentist and determine the patient which the instrument was used on. It might not have been your patient, but one of your colleagues' patient 2 operatories down. So you want to make sure you know whose dirty needle that was. Review the patient's medical history, and then follow any CDC and OSHA protocols for whatever your office or whatever region or state you're working in. Okay, good, thank you. All right, so we're going to talk about the different types of anesthesia. We'll start with intraosseous anesthesia. So osseous is just a fancy word for bone. And then of course, intra means inside of the bone. So this is when we put local anesthetics directly into cancellous bone. This is where the lips and the tongue do not become numb, but only the specific area where we're trying to numb. So special equipment for this is required. So with this, we use what's called a perforator. So what it is basically is a solid needle. So most of these needles that we have are hollow, right? Because the anesthetics need to travel through them. But a perforator is actually a solid needle that is placed onto a low-speed handpiece, right? So like a low-speed drill. And so we're actually drilling into the bone with this needle. So it creates like a little tunnel for the anesthetic to go through. And then we would just use a regular needle to go ahead and push that anesthetic directly into the bone. Okay, so this will anesthetize the bone, the soft tissues around the bone, the roots of the teeth, and it can do either single teeth or multiple teeth. A periodontal ligament injection involves inserting the needle into the gingival sulcus along the axis of the tooth to be anesthetized. So the same area where you would stick floss, right, when we're flossing, right into the gum tissue there, you would kind of plane the tooth a little bit so that the needle goes right into the periodontal ligaments. So this is used for pulpal anesthesia of 1 or 2 teeth in a quadrant. It may be adjunct to another injection where a patient is partially anesthetized, but they might finish off the anesthetic with what we call a PDL injection or periodontal ligament injection. And it can also aid in diagnosing abscess teeth. This is because, bless you, this is because it'll actually, if a patient is having an abscess around that area, it'll numb that abscess. So that way dentists can figure out, okay, yep, this is the tooth. If it numbs that tooth and it makes toothache go away, then this is the tooth in question. Let's go ahead and do root canal on it. Okay. So a periodontal ligament injection system will look something like this. Although I just want to point out, it doesn't have to. You can do a PDL injection with a regular aspirating syringe, but some dentists like to use this fancy device here. It almost looks like a gun with this. You could put a regular needle on it. It just looks a little different. So this is inserted into the gingival sulcus of the tooth, and it requires a special pressure syringe. So this is what this is. So where it'll only give a certain amount of pressure, although most dentists are knowledgeable with how to do this with a regular aspirating syringe. An intrapulpal injection is delivered directly into the nerve chamber. So this can be used when there is a difficulty in securing numbness in the patient, like by traditional methods. So let's say a patient goes in for root canal and already has an abscess tooth. So we drill down the tooth, we access the nerve chamber already, right? We're about ready to do root canal and they're still feeling pain. So what the dentist will do is they'll actually get a needle and they'll stick the needle inside the tooth, right through the nerve chamber. This can be very painful for a split second until the anesthetic is delivered. And then suddenly the whole tooth becomes numb and the patient no longer has any pain at all. So it's a very effective injection, and especially when we're doing root canal therapy where there's severe abscesses. The only thing is it can be very, very painful when delivering the first puncture into the pulp chamber. Okay, electronic anesthesia isn't really used very much. Basically just shocking the tooth with electricity. It's used alone. It has low to moderate levels of success, but sometimes when it's used in combination with nitrous oxide, the effects are a little bit improved. So this type of anesthesia can be used in patients who have an adverse reaction to anesthesia, are allergic to some types of local anesthetics, or are very fearful of injections. So we can use this for placing restorations, to relax muscles, and determining the area of centric occlusion. So patients that have TMJ issues, and we want to figure out exactly where their bite is because they have such bad TMJ that they can't even figure out where their bite is. We'll use it for things like that, but it's not used very often, if ever. I don't think I've maybe only seen it used once in all of my years of doing this. So I don't expect any of you will ever even see this being used. Okay, computer-controlled local anesthesia delivery system uses a microprocessor to deliver controlled pressure and volume of anesthetics to a site. So this will deliver pain-free injections, and it can be used for all traditional infiltrations and nerve block injections. I believe there's a picture of one of these machines. Yes, it's on page 462, figure 20-24. It's basically just a regular injection, a needle that has, it's controlled, it's connected to a microprocessor, and it very slowly pushes the anesthetic in, and it usually vibrates so that the patients don't feel it very much. Okay, let's see, what do we have next? Okay, nitrous oxide. So nitrous oxide is a safe, stable, non-flammable gas that is used to relax and comfort patients. Does not take away pain. It basically, all it does is it produces a calming, euphoric sensation for the patient so that they go into the procedure. They don't really care what you're doing with them. You can do whatever you want. I like using it because I like the effect that it puts my patients in, because working on a very anxious patient isn't very fun. But the thing is, you have to get a lot of things out. It's a lot that you have to kind of set up for them. And then once you have a patient under nitrous oxide, you cannot leave the room. You have to be in the room with them at all times. So the cool thing about nitrous oxide is some states allow the dental assistants to perform this task under dental supervision. Other states only allow assisting dentists. So Arizona is one of those states where we can administer nitrous oxide on our own. Okay, so usually I'll put them at what we call a 50% ratio. So the patient has to be under both oxygen and nitrous at the same time. We can't ever deliver nitrous only. The reason for this is because that nitrous gas will actually compete with the oxygen. So if a patient is breathing only nitrous gas, they are not getting any oxygen. So we always have to give it with a safe mixture of pure oxygen. So that's usually about 50%. Sometimes it's lower, sometimes it's a little bit higher. But a lot of these machines here, like we see here, have a safety device that won't even let you administer nitrous unless you're also giving them oxygen. So the patients who can benefit from the use of nitrous oxide often have a fear of dental treatments or have a sensitive gag reflex. And to ensure patient safety, their health history should be kept current, and the dental assistant should closely monitor the heart rate, their blood pressure, their respiratory rate, and responsiveness of the patient during treatment. So usually you want to ask the patient how they're feeling and ask them often. And then you want to adjust the flow for that specific patient. So that's another reason why you want to be in the room with them at all times. You want to always be engaging with them, always be asking them questions. Small talk is really good for this type of procedure, because we want to make sure that they're still engaged with you. Even if they look, high or whatever, it's okay, just as long as you're still talking with them and making sure that they're still conscious. You don't ever want a patient to become unconscious with nitrous oxide, because then it's hard for you to assess whether or not you're giving them safe levels. Okay, so some contraindications or reasons why you shouldn't give a patient nitrous oxide are if they have a blocked nasal passage. Okay, this is for obvious reasons. The masks for nitrous oxide only go on the nose. So if they have a blocked nasal passage, they're not going to be getting any nitrous oxide. Instead, the nitrous oxide is going to be dispelled into the room, and you and the dentist are going to get nitrous oxide and not your patient. Okay, that's not what we want. Also, for patients that have emotional instability, we never know how they're going to react. Okay, sometimes they can be calm, and sometimes they can just go, they can just be crazy. Okay, so if they have some type of emotional instability, don't use it on those patients. Drug users are another one, because we don't know how they're going to react with this type of drug. Also, patients who are in their first trimester of pregnancy, this is a huge no-no. Anybody who's pregnant at all should not have nitrous oxide. This is because it can cause premature delivery. So a patient who is in the first trimester, obviously we don't want that. If there is anybody in the office, even I'm talking like a dental assistant or front office worker who is in their first trimester of pregnancy, they should not be in the office during nitrous oxide use. This is because sometimes the nitrous oxide can be dispelled into the room, and it can be very dangerous for the baby. Okay, also patients are at risk of bone marrow suppression, in vitro fertilization procedures, or if they have any neurological issues, they should not use nitrous oxide. Okay. Who can tell me why might nitrous oxide be used for dental treatment? Okay, don't forget to turn off your mute if you're answering.
If the patient's pregnant.
Well, why might we use it, I guess?
Oh, why might we use it?
Yeah.
All right, give me a second.
It helps to calm the patient down.
Right. It helps calm the patient down. Exactly. Oops. So let's see. Come on, slide. So it'll reduce anxiety and then provide some type of relaxation for your patient. Okay. All right. Any questions with this chapter at all? Okay, good. So what I'm going to do is, let me see, I'm going to stop this share. We still have a few things I want to do though. Me trying to figure out how to stop the share. Oh, here we go. All right, so you're only seeing my face now, right? Okay, good. So what I want to do, I want to go over some test questions for you all. Have a chapter 15 test today. You can still all see me, right? Yeah, okay. So hang on one second. Let me just fix the screen here so I can still see you guys. Okay. So I just want to go over some things here. Can anybody tell me what type of drugs amphetamines are? Are they a stimulant or a depressant?
A stimulant.
Right, amphetamines are a stimulant. They're an upper, right? Okay. Are antibiotics effective against viruses?
No.
Right, they only work with bacteria. So anybody who has a virus should not be given an antibiotic. It won't work. Let's see. What is another name for drugs that do not require a prescription?
Over the counter.
Over the counter, or yeah, OTC. So perfect. And then just to make sure we all know, prescription pads, like the doctor's prescription pads, those should always go into a safe or a special storage location. And this is because sometimes patients may have sticky fingers, right? They might, especially drug seekers, they could see a prescription pad laying on the back counter and they could very easily pick it up and put it in their pocket without anybody knowing. So very special handling should be used for prescription storage, prescription pads, store them in a special location, either in the doctor's office, in their desk, or in a safe. Okay, so what has a higher potential for abuse? A Schedule I drug or a Schedule V drug?
Schedule 1.
Schedule 1, yeah, those are the most dangerous of the drugs. Schedule 5 drugs will be like an over-the-counter drug. Okay, let's see. And then what is a drug exactly? Or what can be defined as a drug?
I guess something that alters the way you feel.
Yeah, so a drug is a substance that changes the life chemical processes in the body. So that's just a proper definition for it. Okay, a side effect is an unintended result caused by a drug. If a drug is habit forming, the person has a psychological dependence, not necessarily a physical dependence, but a psychological one. Let me see it. Is Tylenol a brand name or a generic drug?
Is it generic?
Tylenol is actually a brand name, a drug. The generic form would be acetaminophen. And then Tylenol, of course, would be capitalized because it is a brand name. Acetaminophen would not be. Okay, how about aspirin?
Generic.
Generic, yeah, aspirin is generic. A brand name would be like Bayer or something like that. Okay. What is the most commonly used drug information reference? Okay, this is kind of a tough one. I'll just kind of give it to you. So this is the physician's desk reference, the most commonly used drug information publication. This is what your dentist will probably go reach for in case they need to prescribe something for their patient and they don't have it memorized. They'll go and they'll reference that publication. Okay, so this has to deal with prescription forms. Does anybody remember what BID is an abbreviation for?
Twice a day.
Twice a day. Very good, Carly. Thank you. So what about TID?
Three times a day.
3 times a day. Very good. PRN is an abbreviation for what?
When necessary or as needed.
Exactly. Okay. So any person who dispenses a drug or who writes a prescription for a drug has to have what type of number? Or what agency do they have to be associated with?
A DEA number?
Yeah, exactly. Drug Enforcement Agency number, a DEA number. Okay, let's see. Skip through some of these. What is a drug called that is placed underneath the tongue?
Is it sublingual?
Sublingual, yeah, sublingual drug is placed underneath the tongue. Very good. A drug that is directly injected into the vein is called intravenous. Okay, what about a drug that is directed just underneath the skin above the muscle?
Subcutaneous.
Perfect, yep. And then a drug that is injected under the top layer of the skin, so kind of in between the layers of the skin.
Is it intradermal?
Intradermal, very good. What about a drug that's injected directly into the muscle?
Intramuscular.
Perfect. Oh, yes, perfect. Intramuscular. Okay, can anybody tell me what type of drug alcohol is? Is it a stimulant, a depressant, a narcotic? What is it?
It's a depressant, isn't it?
It's a depressant. It's a downer for sure. How about an example of a drug that is both a stimulant and a depressant?
Marijuana.
Yes, marijuana is both, and we never know which one it is. So people are kind of up and down a lot of the times that are on marijuana. So yeah, very good. So the need to have larger amounts of a drug to produce the same effect. What is that term called? So someone can develop a blank if they require more amounts of a drug to produce the same effect.
Tolerance.
Tolerance, very good. Okay. What about, who knows the most addictive narcotic? The type of street drug.
Heroin.
Heroin. Yes, it's said that the person becomes physically addictive during the first use. Okay, what is an analgesic?
Can you repeat that?
An analgesic.
Is it something that relieves pain?
Yeah, so something that doesn't take away the sensation like an anesthetic does, but will relieve pain. So this would be like aspirin, Tylenol, Aleve, things like that. All those things are analgesics. Good, good. Okay, let's see. What type of antibiotic can discolor developing teeth?
Tetracycline.
Tetracycline, yes. Very good, thank you. Okay, and this one I'll give it to you. A type of drug that can be given to treat oral thrush is nystatin, Nystatin. Okay, there is a type of drug that can reduce the flow of saliva. This is known as atropine. Okay, and let's see. One more here. So if children are allergic to penicillin, what might the next antibiotic be that we can give?
Amoxicillin
What was that?
or amoxicillin or another one that starts with a C. I can't really.
So you're close, you're close. So if they're sensitive to penicillin, we can give them amoxicillin because amoxicillin is just a derivative of penicillin. But if they're allergic to penicillin, that means they're probably allergic to all forms of penicillin. And so we can't give them any types of penicillin, including amoxicillin. So the next drug we would want to give them is erythromycin. So erythromycin is a very, very strong antibiotic. Can sometimes wipe out all bacteria of the gut, which can give people stomach aches, give them nausea, things like that. So we would want to give yogurt or some type of probiotic to help interact that. Okay. All right. So those are some of the harder ones that I felt like needed some addressing for chapter 15 test that you'll take tonight. Does anybody have any questions as far as what to do? Okay, just to remind you, this is a very, very, very short course. Our finals are this Wednesday, so a day after tomorrow. That's also when your portfolio projects will be due and when you'll need to present those. Okay, so we won't be meeting again tomorrow. Tomorrow there'll be another Zoom meeting at 5:30. But we will be meeting on Wednesday. So I want everybody to be prepared for that. Wednesday, we will be in class all day. So that's from 5:30 all the way to 9:50. So please be prepared for that. Whatever you need to do to be there, because that is your final. We don't want anybody missing that day because that's also the day you have to give your presentations. All right, any other questions for me?
I have a quick one.
Yeah.
So portfolio, I picked a category where you have to make flashcards for like the whole class.
Uh-huh.
So is it okay if I do, like if I handwrite it, or would you prefer me to like print it out?
Can you explain that a little bit more? Like flashcards and
Like for instance, like if I get like index cards and write it on it, is that okay? Or do you want me to like print it out and like cut them up and like paste them on the index cards?
I guess if they're legible enough, then printing
Okay.
it out is fine.
Okay.
Yeah, just make sure it's presentable.
Okay, for sure. Thank
Okay.
you.
You're welcome. Any other questions with either the portfolio projects or with the final or with the class in general? Okay, so if I didn't message you during class to stay after, you can go ahead and we'll wrap up for tonight. There's a lot of stuff that's due for tonight. I apologize, just one of those classes where we spend all of our time doing coursework and not a lot of in-class stuff. So I want to give you enough time to do that. So I'll go ahead and let you go now. But if you have any questions, concerns, comments, please don't hesitate to email me. I'll be available throughout the whole night to answer any questions that you may have, okay? All right, that's it. I will see you all tomorrow.
Thank you.
All right, thank you.
Bye.
Bye. Okay.